Cough dropped her over there. So.
Keep smiling.
Dog.
What is everybody having all these problems today?
I don't know.
Press Alt A. Okay. Yeah, all the new Kleenexes too. Grab that.
Might hit system hiccup here, so kind of bear with me, please.
Okay.
Get the phone out of here.
Step in and start talking. That's right.
That's not us.
Dr. Mageto, would you mind turning off your share for one moment for me?
Finally.
What?
Do you mind turning off your screen share for one moment, please?
Sure.
There.
All right, and let's see, Dick, if you'd, there we go. And I apologize for the hiccups we're having, but we're trying something brand new this morning, and I'd like to welcome everybody to our meeting. This promises to be such an exciting meeting. We've got some people that have not muted their mic, so I'm going to ask you, if you're not muted, you mute your mic, please. And because if you're not muted, what happens is when you talk or say something, Bruce, known as an example, you're not muted. Joan Head, you're not muted. Other people are not. If you please mute yourselves, and you do that by going to the bottom of your screen, you'll see a little microphone. If you click the mute button, it'll silence your speaker, your microphone. Because otherwise, when you talk, and if Dr. Mageto is making her presentation, you will override her presentation. And as much as we love to hear from you, I think we'd even more like to hear from her. So I'd like to say welcome again, and this is going to be an exciting meeting. We have so much happening. And this meeting, by the way, is reaching not only our PF Warrior community here on Zoom, and we have 157 people that are registered for this meeting. Karen, would you turn off your share, please? Okay. Not only will this meeting reach 157 people that are registered on our Zoom meeting, but we're also broadcasting simultaneously on YouTube, on LinkedIn, on Twitter, on Instagram, and both our Facebook page and our Facebook group. So as you're looking at this meeting, we're having over 1,000 people joining you in participation and watching this. And it's the largest meeting we've ever done. We're really excited by it. And the technology is just, when it works and you don't have operator error like we had a little hiccup this morning, as I was telling, with some of these new features and functions we're bringing online. Plus you can't see it, but behind the scenes, I'm here feverishly clicking that admitting people that are coming a little bit late. So with that, I'd like to start off by introducing Shelley Mathis. And Shelley Mathis is our Vice President of Meetings and Events and is responsible in large part for speakers like Dr. Mageto, who our member Dick Morgan is going to introduce and talk about. But Shelley, I'd like you to kind of do a little recap, if you wouldn't mind, about some of the exciting things that are happening, because we have so much taking place.
Well, first, thanks everybody, all 1,000 of you who have joined us today. This is really wonderful, and I want to thank Bill Vick for making this possible. I'm the least technical person in the world, and Bill might be one of the most. So this is all happening automatically. If you haven't visited our new webpage, it's fantastic. It really is. And on the new webpage, there's a donate button. And I see that many of you have been making donations. So keep up the good work. We're very grateful for all of them. And it's wonderful to have your support. not only do we have Dr. Mageto today talking about PF 101 for all of those of you who have been newly diagnosed or are just managing the condition. On our next Thursday meeting, which will be August the 27th, Dr. Aryeh Fisher is going to make a presentation, and he has a very interesting take on lung inflammation and autoimmune problems that you'll want to hear. They're very fascinating. Then our September meeting on September the 12th, Dr. Chad Newton, who is sort of a specialist now in telomeres and genetic sequencing. He is going to be our speaker. And then September 24th, which will be another Thursday meeting, Janae Woodruff with Behringer is going to talk a little bit about being a caregiver for people with PF. And we're going to try to do some breakout groups where we can all talk privately if you're a caregiver or a patient. So that will be another interesting experiment. So now I will turn the program over to Dick Morgan. He's been one of our most helpful PF warriors. I appreciate everything that he's ever done, and he'll introduce our speaker. Thanks, Dick.
Dick, you're muted.
Yeah, Dick, turn on your.
Thanks, Shelley. Thanks for correcting me on the mute. I thought it'd be appropriate to put up my background with the bull, since Bill has introduced me very kindly as the bull guy here today. So I want to live up to my reputation. Our topic today is entitled "Pulmonologists Take Over the World from Hospital Administrators and Politicians." The subtitle is Pulmonary Fibrosis 101. Dr. Yolanda Mageto will discuss the basics of interstitial lung disease, ILD, including pulmonary fibrosis, or PF. Whether you're newly diagnosed or you are an experienced hand, you will learn much more about the different types of PF, why it is so hard to diagnose, what the latest treatments are, and why there is hope on the horizon, and maybe even more. Dr. Mageto is the medical director of the Interstitial Lung Disease Center at Baylor Scott and White Medical Center here in Dallas. She's a clinician, an educator, a researcher, and she has been involved in multiple IPF and ILD clinical trials for over the past 20 years, including collaborations with researchers from other prominent medical centers. In spite of a full schedule of clinical work, Dr. Mageto remains actively involved in the total care of her patients. I know. I'm one of her patients. When she is not at the clinic, Yolanda enjoys her family, travel, reading, cooking, and hula dancing. Of course, I lied about the hula dancing part.
Hey, you don't know. Maybe you're right.
Maybe. But seriously, folks, after her residency at UT Southwestern Medical Center, she completed a fellowship in pulmonary and critical care medicine at the University of Washington in Seattle. She later held faculty positions at the University of Washington and at UT Southwestern. She was a full professor at the University of Vermont. Strangely enough, the PF Warriors Support Group now welcomes Dr. Yolanda Mageto. Go for it.
I think I might try the hula dancing. It's COVID. Try something new in life here. All right. Good morning, everyone. And thanks, everyone, for inviting me. I'm delighted to be here.
Yolanda, you're cutting out a little bit.
Okay. Hold on. you guys hear me now? Is it better?
Yes.
Okay, good. I'm going to share my screen right quick so we can get started. So I'm really happy to be here this morning. Let's see, that's the correct screen. All right. Assuming everybody can see the screen, at least I hope you can. So I was asked to speak about the basic, and I had to think about this, and that I decided to think about it the way I usually deal with it in my office when hopefully by the time we get done, you'll sort of have a feel for why this is fairly complex. And I have colleagues who look at me and say, you know, I hate doing ILD. It's really hard. It's really complicated. I actually think it's fun if you like puzzles and figuring things out. So let's start from there. So there we go. For years, ILD in general has been a castaway island in the medical world. If you ask anybody under the age of, I don't know, I'd say 25 maybe, what half of these things are, they probably would look at you like they're insane and not have a clue. What I find is interesting that books are also on this island and certain other disorders. What I hope is that in recent years, due to people like you guys, that you have warriors and patients who are willing to advocate for themselves, that we're no longer on the castaway island, that we've come a lot further and we don't have to sit outside anymore, that there is a seat at the table for patients with interstitial illness. Let's start at the beginning. So definitions. You know, this has been around a long time, and this is one of my favorite definitions because it was written by Sir William Osler in 128 years ago. And I'll just read it. Chronic interstitial pneumonia, which is actually the same as ILD, or cirrhosis of the lung, which is what they called it back then, is a fibrinoid change which may have its starting point in the tissue around the bronchi and blood vessels, and we'll go through this shortly, the interlobular septae, the alveolar walls, and the pleura. So diverse are the different forms and so varied are the conditions under which this change occurs that proper classification is extremely difficult. At 100 years later, that still stands, although we're better than we were. We've made progress. So I read it for people who aren't familiar with a lot of the language in there. I think, okay, let me say.
I mean, through very badly.
Pardon me?
Impossible to hear.
Let's see.
The audio is terrible.
I'm trying again. Can you guys Bill, anybody?
Yeah, your audio was breaking up, Dr. Mageto, but
All right, give me a second. Let's see if I can go to my settings here. I'm gonna stop sharing for 1 second and see if I can get to my
we both had audio problems this morning, and my guess is you're on a Wi-Fi connection, and Wi-Fi but you can't fix that or change that. But your settings might allow you to increase your volume.
Yep. So I'm gonna go to figure out how to fix my settings.
One of the things about using this is kind of bleeding edge technology we're using, and we're doing something as, to my knowledge, has never been done before. You think about having a meeting like this that's being shared across so many different social media sites. So what you're seeing here is on YouTube, it's on Facebook, and both our page and our group. It's on LinkedIn, it's on Instagram, it's on Twitter. So the universe we're addressing is huge, and the hiccups we're having with the systems and the hardware and the software, sometimes this is all fairly new technology, and hiccups are expected. Audio, surprisingly, is more important than video in a meeting like this. And my microphone didn't work this morning. I know Shelley had some problems as well coming online. So we'll just do the best we can, Dr. Mageto. At worst case, you can remember the old ad on TV for FedEx of talking with your hands. We might have to do that too. So
I have to do that. Let's see. I'm going to look at
One thing you might want to do is close all of the applications on your computer except for your PowerPoint and your Zoom.
Yeah, I pretty much have everything else shut down. I'm just going to quit everything. Doesn't cause us trouble. Let's quit that. All right, so is that any better at all? Hang on, I'm going to try.
It's much better, Dr. Mageto. It's much better.
Okay, because I've set the setting to go to automatically adjust.
All right. It might break up a little bit, but the message is coming through. The slides are just dynamite. So
Let's get back then to the lesson. Okay, so sharing, let's share the screen again. My guess is nobody's seeing my screen, are they? Let's stop the share.
you might want to make your share screen a full screen size, Dr. Mageto.
I'm gonna switch it. Here. All right, let's go. Share screen. All right, it didn't like that. So now share. Okay, access, guys. Unique.
That's perfect. And you might want to close that little settings window that popped up.
Okay. So getting back to definition, really the bottom line is here is that this whole process starts with inflammation and scarring in the lung. And that includes the airways, blood vessels, or alveolar sacs. So the conditions that lead to this are just so varied and so different that we really have a hard time classifying the disease. So in the beginning, there was normal lung. And this is what a normal lung should look like if you were to take your lungs out and just look at them. They're pink, they're just really sort of this sort of pink with little patchy areas of white, but this is what a normal lung should look like. 3 lobes on the right, 3 lobes on the left. And these are the airways where your breath goes in when you breathe. The airways, so as you take a breath in, so I sort of went through the anatomy, and I want to go through this because when we talk about what's actually happening, it's a good idea to understand what's going on normally. So as you take a deep breath in, the air goes down into your airway, and there's a little epiglottis here that actually shuts down and covers it when you eat. So the food when you eat goes down to your esophagus and stomach, and doesn't happen to end up in your lung, which is where you do not eat. And as you breathe in, this airway gets divided and it goes down smaller and smaller until it gets this very tiny airway down here. This duct here is a small sac. It's the equivalent of a leaf on the tree. It's my favorite analogy. I'll tell you in a minute why. But these tiny air sacs are called the alveoli. And at any point from where I started, right about here, going all the way down, any damage that happens there, any inflammation, any process can be put under the interstitial lung disease umbrella. So thinking about it, here's my thing. I always tell my patients, think of your lungs as an upside down tree, and the trunk is hollow, and you breathe and the air goes to both sides. And if you look at this, you can see it looks like a tree, and the branch is going out. And when you get to the end of the branch, you come to the air sacs, the alveoli. And they are covered with super fine blood vessels. And if you want to imagine it, look at the back of your hand. It's the same idea of the veins in the back of your hand. And on one side comes in the blood with the oxygen, and it delivers it as you breathe in, comes by, the blood is coming by, it's picking up the oxygen, it takes it to the rest of the body. And it drops off the CO2 or the carbon dioxide that you don't need anymore. And so there's this nice little two-way highway going. One goes out, one comes in, and that's what should happen normally with normal gas exchange. Now, what happens really, from a much closer level, I'm going to break it down even more, is that air comes in here. It goes in and out, as I just showed you. Carbon dioxide comes here, oxygen goes into there. There's a couple of things that can happen right down here which gets you into trouble. So this is lined with these tiny cells that are almost, it's what I call a potential space. There's no real space, just cells that are so tiny that you have to use an electron microscope to see them. And in here, you've got a little bit of fluid so that the lung doesn't collapse. So if you think about it, everybody's got these rubber gloves at home now that we have COVID. Or better yet, when you go to the grocery store and you pull down one of those plastic bags to put fruit or vegetables in, and you can't get it open, and you can't, get some water or anything because there's nothing there unless you go over to where there's something wet. And when you use water, it opens. It's the same thing as the surfactant that lines the lungs. It keeps it nice and open so that air will flow smoothly. So you can imagine anything that goes wrong at any point is where we're going to get into trouble with lung disease. So having said that, what happens when things go wrong, when you're not breathing right? In interstitial lung disease, inflammation is the beginning of change. The symptoms, the course, that's going to vary from person to person, but the link can start with inflammation. There's some type of injury, something you're exposed to, something you breathed in, some medication you may be taking, something that your body does not respond to or sees as foreign, and it responds by inflammation. That's something the body does when it's a way of fighting things that shouldn't be there. So if this happens in those tiny little airways just before they go into the sac, we call it bronchiolitis. If it happens in the airways themselves, we call it alveolitis. And sometimes your doctor may say, well, you have a lot of ground glass on your lung. That means you just got a bunch of inflammation right around those little tiny air sacs. And then those blood vessels, the other way you can have it is that's inflammation too. And we call that vasculitis or inflamed blood vessels. And then fibrosis is more when you have burnt out the other end of inflammation. So what happens then when things go wrong? Well, let's see, you're breathing in, the body does what it's supposed to do. So let's say you breathe in something foreign, something that's not supposed to be there. The body's response is, okay, it sends off the alarm, and all these cells that we're looking at rush in to the battle. And they have this wonderful war. And at the end of the day, they should clean up and move out and everything goes back to normal. Well, with pulmonary fibrosis or any interstitial lung disease process for that matter, particularly the fibrosis part though, is what happens is that it comes in, you start the inflammatory process, there's some scarring, but when it's supposed to revert and go back to normal after everything's done, it doesn't. So it's like the old LP of the records where, or the CDs where it would get into a groove and it would just repeat, and keep depositing, and then the groove gets deeper and deeper, and eventually you can't, it's irreparable. It's the same idea in your lung. Once it gets to a certain point, there's no going back, and what is done is done. What typically happens with fibrosis in an ILD, which is what makes it harder, is that these things happen at different places in the lung at very tiny levels and eventually coalesce to one big process. And that's when we have our sickest patients. So just a sort of pictorial look at this, normal lung over here, nice little airways cut across, blood vessels. And then on the other side, going back, when all this scar tissue comes in, you can see how it pushes those airways and stretches them. And guess what? All our blood vessels went away. So how do we get oxygen? It doesn't happen. Or we get much less than we're supposed to, and patients are short of breath. And that is one of the reasons you're winded or you need oxygen in order to breathe. Sometimes I think a picture's worth 1,000 words. So this is a normal lung here on the far left, my left. In the middle and over here, these are lungs that are scarred up, sort of end stage. These big holes you see in here are what we're calling honeycomb cysts. And this is all fibrosis. So if you were to touch this, it really would be hard and very firm and brittle. As if you touch this over here, it would be very soft and sponge-like. And that's the difference between the two. So it sort of gives you an idea of what's going on inside when people say you have pulmonary fibrosis, regardless of cause. So having said that, you can see that there's so many points, so many touch points in the system when you're breathing where things can go wrong, that diagnosing interstitial lung disease can be difficult. And this is where my colleagues who don't do this a lot get really frustrated, because we're talking about over 150 diseases here. And a lot of them present the same way: shortness of breath, cough, fatigue. And so I've got to sort of, dig through, and it's like finding a needle in a haystack on some occasions. And sometimes the answer is very obvious. But the successful management is really important on getting an accurate diagnosis. And by doing that, I can say, okay, what's your prognosis? What's our plan? What's going to be our method of attack? And are we going to be doing the right thing for you? And you can make plans because you'll know what we're dealing with. Going on a little bit more about the inflammatory piece. Some of you will say, well, does anybody ever get better? Well, from fibrosis, it doesn't reverse. But there are some types of interstitial lung disease that are purely inflammatory and do respond to treatment, and patients do get much better, and they may even get off oxygen if they're on it. And so this is sort of a little cheat sheet of what we call the idiopathic interstitial pneumonias. They're a group of interstitial lung diseases. These, which are here with the inflammatory group, they tend to get better. The fibrosis group, they don't tend to get better, and much of our approach to treatment is stopping or slowing the rate of progression right now. We're still looking for the magic bullet for the cure and the reversal, but as of now, that does not exist. So when I think of interstitial lung disease, I say it's chronic. And this is key, because when people are first diagnosed, they're very frustrated. You used to walk 18 holes of golf. You used to be able to hang out with your grandkids or go on trips with friends and family and keep up. And now you're noticing this is more and more difficult. So we very often have to have a conversation on living with the disease as opposed to living for the disease, or the disease running your life. And that's a mindset that takes time, but it is one that can happen. And I find that people who manage to do that, they tend to do better. Less stress, they just seem to have gotten along. Even wearing oxygen, which is a huge battle I have with some patients because they don't like it, and I can't blame them. But sometimes you have to get a sense of humor. I had a patient who who named her oxygen tank. It was George. And George would come to the office with her every time. And it was great. We used to joke about George, but it was just her way of dealing with the idea that she needed to have a tank. It's chronic. Most of these, we don't know what causes them. There are some specific, and we'll go through those later. And then a lot of them have a genetic component. And I'm sure someone's going to ask me about genetic testing, but I'll talk about it in a little bit. So the genetics here can influence your susceptibility. So how likely are you to get it? How severely are you to get it? And will you respond to therapy? They are much further along in the cancer world than we are in the ILD world when it comes to genetics. Symptoms for most people will be shortness of breath. And I always say, most people will tell me they're short of breath for 2 or 3 months. When they're telling me that, the spouse is usually in the background shaking their head or interrupts and saying, no, you're not. You've been short of breath for double or triple that time. And that's because most of us will adapt to being short of breath without knowing it. And sometimes you have to go back and really think about your activities and what you did and used to do. For a lot of people, they have a dry, hacking cough, extreme tiredness, no appetite, sometimes weight loss, sometimes labored breathing just by talking. And some interstitial lung diseases actually cause bleeding within the lungs themselves. And you may or may not cough up blood. You may just be short of breath and have a very specific appearance on the CAT scan that we get. What your doctor also might find is an abnormal x-ray. They'll do PFTs, we'll talk in a minute. And we do a test called a diffusion capacity. And we also do a 6-minute walk test. My patients love to do this every single time they come to the office. They beg to do the 6-minute walk test and PFTs. So let's see how we do this. So let's just back up. We talked a little about the normal lung. We talked a little bit about what goes wrong. We talked a little bit about what those lungs actually look like. So what should a patient actually do? I mean, how do we actually figure this thing out? You know, how do we get to the point where this is your diagnosis and this is what we're going to do? Really, we have to be medical. Very biggest thing is we need a comprehensive medical history. And that means we're focusing on your, so we get really nosy. We want to know about where you worked, what you were exposed to, what your family history is, any medications you've ever taken. We're picky about time course. We want to look at your PFTs, our exams. We do a lot of things. So for our office visits, our first visits are usually at least an hour. And a lot of that time is in conversation, not even doing stuff. But doing stuff is a separate visit from that. So we always warn people, you'll probably be here for most of the day or at least half of it when you come in for your first visit. All right. There we go. So that medical history, that shortness of breath, really important to figure out how long it's been there, because it sort of puts us in a category as to how fast your disease is progressing. It gives me an idea of what category of interstitial lung disease you might fall into. The cough, some people have it, some people don't. Those of you who do know that it can be quite debilitating. Usually it is a dry and a hacking cough for most patients. One of the other things that, at least at the ILD centers, and you're having R.A. Fisher talk to you, and he's got a lot to say on this. He's a great rheumatologist, but we have, we will ask all these very interesting questions that people will say, well, what does that have to do with my lungs? What does joint pain have to do with it? What does a history of blood clots or skin rash or even, you know, a history of miscarriages? What most people don't know is that autoimmune diseases actually can affect the lung, just like they can affect your joints and your skin, they can affect your lung directly. And there's some other disorders that can do that too. So there's systemic, what we call systemic diseases that affect the whole body, including the lung. And then there are diseases that affect the lung and the lung only and no other organ in the body. So first thing we do after we've had, you know, our conversation, we do our exam, we're listening to your breath sounds, and we're listening to see if we hear any Velcro rowels. Usually this sound, this very kind of, you can hear that, but it's not quite that fast, but I'll hear that sound usually at the lung bases. That's a hallmark, usually for some early scarring or late scarring. I will not hear wheezing. If I hear wheezing, it will be inspiratory. So I'll make you take a deep breath and I'll hear the wheeze. If I hear you wheeze when you're breathing out, then that's probably not interstitial lung disease. That's probably related to asthma, COPD, and something else. Now, could you have both? Absolutely. I've got patients on both ends of the spectrum with both diseases, which is a whole new story. We do physical exams, and so I like pictures. So these are things I look for. Like, do you have these are signs of autoimmune disorders that people get that affect the lung. It can cause pulmonary fibrosis. And in some of these cases, some types of autoimmune diseases can cause the fibrosis to progress even more rapidly than IPF. And then Raynaud's, where your fingers turn purple in the cold, or when you stick your hand into an ice bucket, or this is clubbing down here, where we see people with long-standing lung disease. Their nails will change over time and they get that spoon-shaped picture, which is usually an indicator of lung disease. And this is a patient I had years ago who also, interestingly enough, had her hands look like this, which was scleroderma, and then like within 6 to 8 months, they had progressed to that, and that's very aggressive disease. So some people have, and the lungs followed. With autoimmune disease, the lungs tend to do the same thing that the disease is doing systemically. So it's all raging inflammation going on at the same time. The more objective things we do is send you for PFT. So the breathing test, the reasons we do these breathing tests is that they actually tell us, and I like to do them sequentially because they give me an idea of how your disease is progressing. You may tell me you feel better or you may not feel better. You may feel the same, but if I see your numbers dropping progressively, even by small amounts, that gives me a clue that there are things going on that maybe you aren't feeling yet, and there are things that we need to do. We do the diffusion capacity where you have to pant into that, and that gives me an idea of how well your oxygen is going across into the lungs and back and forth. What's going on? That, remember that alveoli I showed you with the gas exchange, it tells me how well that's actually happening or how bad it is. We're looking to see if your oxygen levels are dropping when you walk. Do we need to give you some oxygen to help your bodily functions go on, normal? And I tell people it's like oil in your car. You don't drive your truck without oil. So oxygen is like the equivalent of oil. So if you need it, you should use it. However, that doesn't always go over. So I still have to have this discussion a lot of times about wearing oxygen. Genetic testing. So it is really not recommended right now in general. And here's why. We do know that there are specific genes that are associated with pulmonary fibrosis and certain illnesses. What we don't have a good handle on is what this means to you from a clinical standpoint. So does that mean I should test every single member of your family? And if we find it, what do we do if your family member has no symptoms and they feel good? Do we get CT scans every year? Do we, what does it mean to them? This is something that is ongoing research, and I'm sure Chad will have plenty to say about this in a few weeks. But it is the telomere issue is probably the most well-known amongst the genetic mutations with pulmonary fibrosis. There are several others, but as I said, right now it's difficult to know what to tell you if you have it. What are you going to do about it? It doesn't change a lot, other than maybe the telomere group, which has to deal with transplant patients because they have a tendency to rapidly progress. It's called short telomere syndrome. So then I get to send you the blood work. So after I do all that, I've talked to you, I've examined you, I've tortured you in the PFT machine, and one more bit of torture before you leave is to the laboratory. And it's Halloween for us over there that first day with lots of blood tubes. And that's because we are ruling out blood-wise anything that can tell us what you have. And this is sort of the last step before we start talking about biopsies. If I can figure this out, or if these things come back positive, do you have liver issues that can affect the lung? Do you have a connective tissue disease? Is there some type of inflammation of blood vessels? Anything in there that can give me a clue to what is going on and what's causing your interstitial lung disease, sorry. This I just wanted to include because I know we often get CAT scans, and sometimes you get lucky and your doctor will show it to you, and sometimes they don't. On the left is a normal scan, and the way we do those, you lie on the table, look at the ceiling, you know that, and then we slice you like a loaf of bread. That's sort of how it does. And this flat surface right here this is the heart in the middle, and this is the lung, and this is normal. These little white spots are those blood vessels I told you about. This is not normal. These little holes are all the honeycomb lung and the fibrosis, and you can see the distortion and the abnormal look. That's what we're talking about with all the scar tissue that's laid down. So that's what your lungs look like on the inside if you have really severe pulmonary fibrosis. If you have mild fibrosis, it's not bad. Finally, if we can't with all this other stuff, then the next step is we would recommend a biopsy. Now, I will say this, and people ask this question all the time. If I know you have an autoimmune disease or some known cause of pulmonary fibrosis, there is no need to do a biopsy at that point because we have a diagnosis. The only reason to do a biopsy is if we do not know what you have. And for me anyway, it is going to change my management of your disease. If it's going to affect that, then it is worth the risk. Now, there's 4 ways we can do this. We can do the bronchoscopy, which some of you may have, and get biopsies that way, which is okay. Now, before we could never make the diagnosis this way, but there are actually new, Veracyte has this wonderful test that allows us to differentiate UIP now, doing it this way as opposed to going to the surgical lung biopsy. So now we do have options we did not have before. Then we have the fine needle aspiration if you have lymph nodes. We have the cryobiopsy, which by the way is interesting in that what they do is they put a probe down there that's like, it's all frozen and it just literally freezes directly to the lung tissue and then they yank it out. It's not my favorite, but there are a lot of people who are doing it now and they swear by it. You do get bigger tissue samples and you may be able to avoid the surgical lung biopsy. Most biopsies nowadays are relatively safe, although there is risk, absolutely. Usually it's a hospitalization and general anesthesia for 2 to 3 days post-op, but we can get the most generous samples and can sample multiple lobes of a lung and get a really good feel for what might be going on. So, if we want a definitive diagnosis in patients, if we haven't figured it out by here, then the biopsy is the next step. I do have some people who do not want to get a biopsy, so we have to figure out a way around that, and we can, and that's a case-by-case basis. So you would think you'd get the biopsy, you'd have your diagnosis, I'd say this is what you have, and we're all good. So, well, let me tell you what, I wish it was that easy, but it's not. So let me make it harder. A lot of you have heard something called usual interstitial pneumonia. And a lot of times, every time you hear it, people will say, oh, you have UIP, you have IPF. I've even heard medical professionals say this. This is 100% not correct. If you have UIP or usual interstitial pneumonia, it's a pattern. It's a pattern on your CAT scan. It's a pattern on the biopsy. It doesn't make the diagnosis. It has to be, you have to look at that in conjunction with the medical history, all the other tests, and put the entire picture together before you can make it. So UIP with no other causes, nothing autoimmune, no exposure, no medication, that is IPF, idiopathic pulmonary fibrosis. If it's UIP, and let me guess, you had 4 parrots that you had for 10 years, or you have 500 homing pigeons, that's a true story. You've some exposure to mold, something that I know causes hypersensitivity pneumonitis, different diagnosis. Or you're a plumber who was exposed to asbestos in the days where they wrapped pipes or, worked in the Navy in the engine room, then that might be asbestosis. Or you have rheumatoid lung disease and rheumatoid arthritis, and I know you have rheumatoid arthritis. This is not IPF. You do not have both. If you have a known cause, and I'm saying this because this always comes up, and some doctors out there, if you have a known cause of your fibrosis, you do not and cannot have IPF. By definition, IPF is idiopathic, which means we don't know what causes your fibrosis, but we know you have it. And we've ruled out all known causes that we can have. And finally, if you get a sense, of the complexity, a few more slides here, but it takes a village. I mean, we really need people who are, this is a boutique, almost a boutique type disease, if you will. And it is that way in the sense that pathologists, radiologists, they need to be able to know how to read this. I've seen misread CT scans, misread biopsies, not because people's heart weren't right, but they didn't have the experience to pick up the nuances and get it right. And that matters to you, the patient. So it's imperative to me that when we're doing this, we're dealing with people who actually do this a lot and they understand the disease and they understand it well. It's also imperative that your primary care physicians recognize that there's something going on and get you to a pulmonologist quickly, and you don't get on asthma medication or COPD medication for like 6 months to a year. Unfortunately, outside of an interstitial lung disease center, it takes 2 to 4 years to get a diagnosis with a lot of the interstitial lung disease, which I'm sure some of you can corroborate on the phone here. So what do we do to treat? So Dick mentioned the latest, greatest treatment. To do that, I'm going to go through 150 diseases in iterations. So what I'm going to do is I'm going to give you the 30,000-foot view, and then with your questions, we can hone into something maybe more detailed. So let's talk about medications. We use those to help slow fibrosis. There are 2 approved and still multiple clinical trials going on with others. For some disorders, like the autoimmune disorders, you will be on steroids or other immunosuppressive agents to reduce the inflammation. Remember, inflammation is our starting point. Reduce that inflammation and get things under control. People who need oxygen should be on oxygen. Rehab is important. Becoming a couch potato is not in your best interest. And sometimes families mean well, but they will want their family member to do nothing and just sit on the couch all day. This is not the way to go. You want to be active, you want to be out there. And then there's clinical trials, and then there's a lung transplant. I'm going to say 2 words about lung transplant. This is where we go when we've done everything else we can. You, of course, have to meet criteria for it, and it is not a panacea, but it can improve quality of life. And current median survival is 7 years from time of transplant. So there's some, some people who don't like those odds, and some people have beaten those odds and then some. And again, there's no magic ball that we have to tell who's going to do what. But one of the things we find is that people get referred too late. You really want an early referral so that if there's anything wrong that's fixable while you're still in good shape, let's fix it. If you have heart disease and need stents, let's do it. If you have a hernia that needs to be repaired, get it repaired. And you may not need to play the transplant card. You may just what I call putz along for a while until what we call age out of the system after 75. But you just never know. And so you keep that card in your back pocket in case you do need it. When it comes to the diagnosis then, at the end of the day, when we've done all this stuff and you're sitting there and you're looking at me and you're saying, okay, fine, I've done all this crazy stuff. What do I have? There's 2 camps and two umbrellas. You'll come under the either we know based on there's a known cause of your fibrosis or there's an unknown. So let's talk about the knowns. They're drugs, so either you were on some medication, amiodarone, bleomycin, cocaine, and macrodantin is a common one that urologists give to people who have recurrent urinary tract infections. So they may be on this for years. And I have seen a couple of cases where people have gotten pulmonary fibrosis from this. Amiodarone is a common heart drug, another one that I have also seen inadvertently cause pulmonary fibrosis. Radiation we do not see so much anymore because radiation's gotten laser, just really laser perfect over the years. So we don't see a lot of that anymore. But the connective tissue disease, I see a tremendous amount. And there are a number of people who come to me with quote IPF. We send the blood work off and they just come back with 1 or 2 of these that are just floridly positive. And may or may not have other symptoms because people will say, well, I don't have joint pain. How can I have rheumatoid lung disease? Well, you have other subtle findings of the disease and you have all the markers in your blood. So, and if we look at your biopsy, there are little subtle findings on there that make us lean on the autoimmune side. So it's autoimmune, in which case the primary goal, number 1, is treat the disease, get it under control. And then if you have fibrosis, we may add in a drug to help slow any additional fibrosis based on recent studies that have come out. The occupational piece, this is why we dig. People who have been birds, mold, farmers, hardwood, people like to do woodworking without wearing masks, hot tubs, air conditioners, humidifiers. There's so many things. There's people who work in labs with rat urine, by the way, can get pulmonary fibrosis from that, which is sort of interesting. Something in some antigen in the urine itself. There's just, if I gave you the list of things, it would be over 100 different things listed that have been documented to cause this disease. So it's really important. And if you have fibrosis from this, the number 1 thing is going to be remove yourself from what the cause is. If you have birds, they have to go. This, I find, most birds are part of the family. So this is a hard one for a lot of people. But it is, it's sort of the difference between breathing and not breathing. So we have to deal with it, unfortunately. Slowly, but we still have to work with it. Infections can do this, certain types of infection. And guess what? SARS-CoV-2, otherwise known as COVID-19, can cause pulmonary fibrosis when people get out of the ICU, and it does not reverse. These patients are now looking like IPF patients. Some of them have, I think the youngest one, 20-something, when they had a lung transplant at Northwestern, I want to say somewhere in a couple months ago. Malignancy, cancer can look like this. And funnily enough, I actually have had a couple of people which look like interstitial lung disease would not get better who I biopsied and turned out to have cancer, not interstitial lung disease. So it's really important to know that if my patient isn't getting better or isn't stabilizing and I don't have a tissue biopsy, I better go in there and figure out what's going on. Vasculitis, the blood vessels, and then there's things like sarcoidosis, which some of you may be well aware of. Cryptogenic organizing pneumonia, which occurs very often after a viral infection, or it can occur just out of the blue. It looks like pneumonia, but it's not. It does respond well to steroids. This set of diseases tend to respond well to steroids, and they tend to get better if you catch them early. Late in the process, you may end up with scarring. So I'm going to segue from here now into IPF. It's the most common of the interstitial lung diseases, and it is the Goliath of interstitial lung disease. This is just a graph, and just sort of to give you an idea. This is a known, all the gray boxes are the known causes. The pink boxes are the idiopathic interstitial pneumonias, meaning there are types of pneumonia that we don't know the cause of, but if you biopsy, they're very specific appearance on biopsy. But these group over here all respond well to steroids. This group over here tends not to. They all tend to be very fibrotic and progress over time. And then we have a whole new class here, unclassifiable. Remember our initial, my initial description by William Osler. So there we still have a group that we can't even classify. But I will tell you, in 98, 99, somewhere in there, we didn't even have this graph. This graph is probably came out in the early 2000s where people started putting together. And over time, we've added to this where we've been able to tease out different ones based on the clinical history and the pathology. And so you can see it's a work in progress, and you can see where it might be a little frustrating to the patient where, okay, what do you mean you don't know what I have? Why can't somebody just tell me an answer? I hope you get a sense of why that might be. IPF, which is the big Goliath in the room, it is the most common. It is defined by what it is and what it is not. Remember I talked about the UIP, and so you'll have that pattern on biopsy, but you have to have an absence of autoimmune disease. You cannot have any history of environmental exposures, no drug toxicity, any of that. Everything has to be ruled out. With that combination, I don't need a biopsy. That is IPF. And there's studies that back that up. Now, what do we do for patients with IPF? And I'm going to sort of segue a little bit and say, patients who have pulmonary fibrosis, we will do the same thing as IPF at this point in time, outside of the addition of treating the underlying autoimmune disease, or if you have treating the underlying autoimmune disease or removing any exposure that's causing it, then we will do the same thing on this list. Education, advocacy, treatment of comorbidities, I'll go into those in a minute, education on the therapies, rehab, trials, transplant, and discussing goals of care. It's really important for you to decide what's important to you. What quality of life is important to you? What, people will say to me, I want to see my kid graduate from college or from high school, or I want to see my daughter get married. Fine, those are goals, let's do it. And we will set up that plan. And my goal is to get past that, but at least we have something in front of us that's where we're going to start, and we're going to go from there. I always advocate that patients should be referred to an ILD center of excellence. There are centers all over the country, and the PF, and they're on the pulmonary fibrosis website. But there are 3 in Texas. There's Baylor, UT Southwestern, and San Antonio. Not every state has one, but most states now do. And here's why it's important. You can see why, if you have that many possibilities to your diagnosis, you want somebody who has some expertise in management, someone who sort of knows the cutting edge and stuff that's going on in terms of treatment and management, and you're not on a treatment that we quit using 5 years ago, and you come in with all the complications having been on that therapy. We also all have access to transplant trials, support groups, education. So in my mind, and patients have actually been shown to have better survival. Now, we could not see every ILD person in the world or the country. So having said that, we always, at least in our center, we always work in conjunction with your community pulmonologist. So if you live 2 states over, you might see me twice a year, but you'll see your local doc, and we'll work together to have a plan in place to help you. So one of the ways this works is we work in conjunction with local and community physicians so that we get to educate them too, so you get the right treatment that you need to get better. So you can see the care is just, it includes your symptoms, it includes managing your disease, it includes education. I always say you are your best advocate. The more you know, the better you're going to be. the more you're going to be able to walk in the door and ask questions. And sometimes I get some pretty tough questions, and that's okay. That's what we should be doing. And then we should be doing what works best for you. Now, one thing that happens that bothers me, and I always tell my residents this, do not get tunnel vision. There's this assumption because you have lung disease, because you get shorter breath, that if you are more shorter breath, it has to be due to your lung disease. That is not always the case. So patients who have ILD, they get pulmonary hypertension. They get emphysema if they're ex-smokers. In fact, pulmonary fibrosis is associated with ex-smokers. I have patients who have asthma with their ILD that sometimes I have to, it's okay, so are you worse because of your asthma, or are you worse because of your ILD? And because the treatment's different. Acid reflux is a very common comorbidity, and we worry about these patients because a lot of them have esophageal dysmotility, meaning that when you swallow your food, it sort of sits there for a while, which puts you at risk for aspiration when you lie down. And then we have sleep apnea, which is also common in up to 25% or more of patients. And that's important because if we don't treat it, your risk for high blood pressure, for heart disease goes up. You don't need that. I mean, we need to minimize everything we can minimize here and just focus on just the things we can. Get the things fixed that we can fix, and then what we can't, figure out how to do maintenance. Lung cancer happens in patients with ILD, and we don't want to miss that. We've seen that a couple of times. And then coronary artery disease is another common one. So we have to keep in the back of our heads, not every time you're short of breath is it due to your lung disease. And so if it's not getting better with routine management of your lung disease, we need to start saying, wait a minute, what else is going on here? What are we missing? So what can you do for yourself here? And what can you do to make the best of your doctor's visit? For me, it's important so you know why you're there and what you want out of that visit. So write down your questions. And I have people who say, okay, they always pull out the question list and they've got it, and that's okay. And I say, go for it, and we go through it. If you think you're going to forget, bring someone with you. Now, right now, because of COVID, we're not even letting family members in, but we'll put you on FaceTime, or I'll call you on the phone and you can listen in on the conversation and comment at will. Also, write down the name of your diagnosis, the medications, treatments, tests. We usually give handouts for that. We also give handouts for new instructions. If you're going to get a new medication, ask why. Ask what it's supposed to do. Ask about the side effects if they're not, how's it going to, because sometimes you'll get through the pharmacy and then you'll see this list of side effects and then you won't take it. And then you'll come back 3 months later to your doctors and you didn't touch the medication and you didn't have that conversation. So if you do find that you're not willing to take something or you're worried about a side effect, call your doctor's office. Let them know. Have that conversation because it's important. There's a reason they prescribed it, but if you're truly terrified, maybe there's an alternative. You want to ask about alternative ways for treatment. There is not a one size fits all sometimes. We also want to know, why are we doing the test? What does this mean? What happens if I do nothing? What happens if I do what I call the no treatment arm? I just come in every few months and do nothing. And then know how you can contact your healthcare provider if you have any questions. So this is resources, and I know that this gets reported and put up, so I know you'll be able to find these. And I'm going to do quickly because I know this is a mega topic and thought. I get a lot of questions on this every visit. It's interesting if something so pretty on the screen is so deadly. I guess that's true of a lot of things in nature too. SARS-CoV-2, which has turned all of our worlds upside down. And in fact, I would normally be in person for this meeting, but maybe it's a good thing in a sense I could talk to more people. But this is what I get. People are angry. Why does the story keep changing? Why does the CDC say one thing today, one thing tomorrow? What do I believe? How can I stay safe? Is it really, I had a patient ask me the other day, are those numbers real? Short answer, yes, they're real. Short answer, yes, we are admitting a lot of people. And right now, a lot of those people are in the 20 to 50 age range. People want to go out and eat. They want to go to the store. They want to go shopping. They wanted to go away. I wish I had the answers, but I'm going to tell you, number one, this isn't going away soon. Number two, we're going to do what we do with everything in life. We're going to modify and we're going to figure out how to work. But the reason why the story keeps changing is this. And this says it in a nutshell. We are building this plane while we're learning how to fly. COVID just landed. I tell people we don't have a cheat sheet. There's no handbook. So as we learn stuff, we change the recommendations. And as we learn more, those recommendations change. The good news is we know how to take care of it much better in the hospital than we did 6 months ago. So patients are sort of doing better than they were because we know the things to do and the things not to do. But for patients like yourselves, and a lot of my patients are worried about their immunosuppressive medications, particularly my patients with autoimmune disease, you actually are somewhat protected because one of the big responses that kills people with COVID is this huge systemic inflammatory response. And by staying on your medications and keeping that inflammation under control, you actually put yourself at lower risk, not higher risk. Because I had some people stop taking their medicine. Oh no, I'm going to get this. Like, no, actually, your immune system is still working. Okay, what it is we're keeping it from overworking and getting into trouble. So my recommendation is keep taking your medications as you are. And if you are worried about them, then please contact your doctor before getting off of them. Masking, staying home, those things aren't going away. Staying away from the grandchildren who are sick, we'll see. Schools are about to start for some people, so I think the next 6 weeks we'll have a new set of recommendations, depending on how that goes. So I'm asking people to be patient. It's frustrating for us too. I'm tired of wearing a mask like everybody else, but I'm willing to do this because I don't want to get sick and I don't want any of my patients getting sick either. So this says while you are more susceptible, chronic lung disease are not at higher risk. You're just more susceptible to the complications. So keep your lung disease well controlled. If you're nervous about the doctor's visit, and I have had some people who want to do telehealth, I will say, you should check with different offices. We are super strict in our office, and most of our patients are COVID tested, but everybody's different. Mail order your medications if you don't want to go to the store, but most of you have great family members that do this stuff for you. But be careful with them too, because if they're out and about, they could be sick. Use your nebulizer, just continue that. One of the things I want to make a comment on is staying up to date on your vaccinations, especially with the flu season being around the corner. Please make sure that you are taking that and get the flu shot this year. It's really important because it's going to be a doozy of a year there. So this is a fun slide. This is one I found on Facebook, which made me laugh or made me smile. These are the things that have happened in the last 3 or 4 months. If you notice, coffee is stable. Everybody still needs coffee, but we don't need our cars. The internet use is way up. Toilet paper was way up, but guess what? Nobody cares anymore. We all live in sweatpants. Alcohol, I see a lot of this leaving the grocery store whenever I go in and out to get my groceries. And the masks, well, I give up. All I'm going to tell you is please wear them. And that's that. So finally, be patient, be good to yourself. And this is my favorite slide, and I keep it forever, is this is what we think it should look like. This is what it really is. And I'm going to stop right there. All right, and I
I
think
mute myself. I have to say this. That was in my 9-year journey of living with this terrible, horrible disease. Without a doubt, that was the best presentation on what this stuff is all about I've ever seen, and I've seen a bunch of them. Thank you so much. Thank you.
Thank you. I have a question for Dr. Mageto. Scott and I have been looking forward to getting the vaccination and figure it'll be, kind of like a flu vaccination. It'll work well for some and not well for others. But even if you get the vaccination and it's said to be fairly effective, would you recommend that those of us affected by PF and families go ahead and continue wearing masks and distancing?
I would, because we don't know yet. So, like the flu vaccine, if you get it, then even if people out there that get the flu, it's
Your
Even,
mic is breaking up again, Dr. Mageto. You might want to better than it before.
how about now?
A little bit better.
All right, I'm gonna try.
There it goes. That was perfect.
I'll
Whatever
lean
you just did.
that works better. I mean, into the computer. So I would say to you, I would still wear the mask just because we just don't know enough yet. The issue is if you get the vaccine, what we don't know is how well the vaccine is going to work. That's the key because they're rushing the vaccine. This is much faster than we ever put a vaccine on. So then at first I would do it until we sort of have a clue. And once we get a clue, maybe you won't need a mask. The other question I have about the vaccine is, you know how you get your flu shot and it's good for 6 months, but then after 6 months, the antibodies are gone. So is this going to be the same thing? After a few months, the antibody's gone and then it's not going to be good anymore. I think there's still a lot of unknowns.
So Dr. Mageto, can I ask a question? Yeah. One is you said that 50% of people last 7 years with a lung transplant. What's the longest lung transplant patient you know? I have a second question, a deeper question. At the cellular level of the air sacs, there are 2 or 3 types of cells, one of which creates a mucus. The other one is cilia or hair-like substance that's supposed to get rid of the mucus. And if it collects there, does that become into scar tissue?
First question, at least as far as I know, I believe there are lung transplants over 20 years.
Wow, okay.
As for your second question, the mucus does not become scar tissue. It'll just become, literally become impacted if it's not liquid enough to get out, but it doesn't.
Okay.
I have a question. Dr. Mageto, I truly enjoyed your presentation. It was superfluous, as Bill had said. And my question is, or not superfluous, I'm sorry. It was very excellent. Okay. My question is about protective face shields. Okay. So my husband is a post-lung transplant for about 1.5 years now. And so we've been having, been told to wear face masks, of course, and we do, but no one has ever really emphasized the shields. And so we got some face shields for our next clinic appointment, and we're planning to use them. And isn't it true that the shields will protect the person who's wearing them, and the mask and will protect others? Now, if that is the case, why are not people pushing the protective face shields as well as the masks? It seems to me like that would be a good approach, but I haven't heard anything really, anybody advocating it. Even the pulmonologists at Houston Methodist, where we had the transplant, have even mentioned it to us.
So you're right. So the face shield protects you and it protects the person you're talking to. I mean the masks, the face shield. So for a while there, we all thought it was just purely, air droplets, although there's some argument now about being airborne. Based on some epidemiological studies and some anecdotal events, there's a thought now that you can also get it through the mucous membranes, meaning the eyes. So that is where the face shield stuff started. We don't know that for 100% sure. So that may be why your center's not going gung-ho. At our center, we have all been mandated that we have to wear some type of either eye protection that is all the way across, like goggles, or the shield. It's another one of those things that's the gray area. We see a lot of sick people every day, so we're probably at higher risk. Teachers who are in a classroom with little kids are going to be at a much higher risk. Somebody who's in an environment with people 6 feet away are probably going to be at much less risk needing a face mask. A face shield than that. So it's again one of those very frustrating things, and it is for me too, is I can't give you black and white because I may tell you something today, and in 2 weeks, it might be totally obsolete, or they're going to come out with some new study that shows something totally different. And I agree, it's frustrating. I would say for you and for the way I look at it is, whatever I need to do for protection, I'm going to do it until we figure this whole thing out and tell me that's no longer needed. But I suspect the reason they're not pushing it on patients is, as far as we know, unless you're in close contact for extended time period, your risk is minimal. So like being on an airplane, that's going to put you at high risk. I would definitely be in the face shield on the airplane. But if I'm in a room and people are widely spread out, it's much less likely I'm going to get it from that person.
Dr. Mageto, I just as a comment and a question, I guess, I would
Thank you.
think when masks for me are something that protects me from others. I'm not sure how much it protects me about getting COVID, but some. Whereas mask, I see protecting me perhaps, but how about others? If I sneeze in a mask, it's not going to have the same dispersion rate that it might in a shield. What's your feeling?
Talking about wearing a shield without a mask.
Wearing a shield to protect mask, I see it is I wear it to protect others, not so much myself. I don't think it's going to stop me, quote, from getting it if I come in contact with it. A shield, I think, would stop it better, but it doesn't protect others. So if I sneeze in a shield, there's dispersion. If I sneeze in a mask, as an example, it's contained. What's your feeling? Is a mask and a shield together the best solution, or
Yeah.
one or the other?
There is data that suggests that the shield without the mask really isn't nearly as protective as the mask and shield. And if you had to pick one or the other, the mask should have priority.
Okay.
But the shield by itself is not as protective as wearing both. And that's because you get air flow up into the mask and breathing.
Dr. Mageto, I have a question about cough. I'm not currently not on any kind of medication, and I'm just wondering, for people that do have that chronic cough, what kind of treatments are being used at this point?
So,
if any?
good question. So it depends on the severity of cough. So in my practice, so there's several ways you can do that. In my practice, we may start with the over-the-counter stuff if that doesn't work. I also suggest menthol actually seems to work really well. A lot of my patients carry big pockets of menthol, and just menthol cough drops and pop them. But a lot of times that cough doesn't respond to those, and when it doesn't, and by those I mean you're taking it consistently, like 4 to 6 hours every day, as opposed to just when you get the cough. So in that instance, it's more like pain medication. If you allow the pain to become so severe, it takes a while for your pain medication to kick in. The same thing with the cough. If you're going to try, you might want to just make sure you're doing it every 6 hours routinely. Now, when that doesn't work, then I go to the narcotic-containing cough medications is one option. Those are all prescription. And for some people, those work beautifully. The other option is a gabapentin, which is on the market for neuropathy, and also could use depression and some other things. But I've had a couple of people respond very well to gabapentin 3 times a day. And there is an Australian study a few years ago that actually looked at that, sort of how that came about. Interestingly enough, my OFEV patients seem to do well with their cough too. I'm not sure why. But those are the things I usually work with, and usually we find some combination thereof that works. It can be very frustrating. Sometimes you just have to sort of play with things back and forth. And you have to make sure that your cough is due to the lung disease, like you don't have acid reflux that's causing your cough, or sinus drainage is causing your cough. So you want to rule out any other possible causes of cough that are treatable.
Dr. Mageto, Lindsay, one of our members, Lindsay Stoner, has a question, and I'll ask it for her. Can you share those wonderful slides with us so we can publish them on our website?
Yes. Happy to.
And while I've got the mic, I have to say to my good friend Jim Ramage, you're getting pudgy. which is the best compliment I could make to you. You're really looking good.
He looks better than Bill.
He does, but most people do. Yes, but thank you. Since Dr. Mageto's here, please don't let this opportunity slip by. You've got one of the world's great authorities on this disease who really has a heart into it and a care into it to ask questions that you might want to ask yourself sometimes in the dark of night, but here she is, so ask her.
I have a question regarding flu shots. Last year I got my flu shot very early, September the 3rd. And I got the one for the elderly, which I believe is a little bit stronger type of a flu shot. But unfortunately, in first part of January, I did got the flu, which resulted in an exacerbation, which now I'm on oxygen. So my question is, would it be, I remember my mother 10 or 15 years ago had COPD, and her doctor used to recommend she get 2 flu shots a year, one early, and then midway through the season, she would get another one like a booster. Is that recommended at all for IPF patients?
So it is not a standard recommendation, but I do tell people that you should get your flu shot. So you got it in September. I usually have my patients get them later in the year for that very reason.
Okay.
Because I want if you get it too early, the antibodies wear off. And I think that's what happened for you. So I usually say, please get your flu shot in late October, early November. Now that was pre-COVID.
Right.
So it may well be reasonable to get it in September, but plan to get a booster shot maybe in December sometime.
Yeah, I think that's what I'm going to plan on doing, because I'm sure that's what caused all this, because I was scooting along very well. And but we were planning a trip to a road trip, and we both thought, baby, we better go ahead and get our flu shot because we were going to be traveling. But I will get a booster for sure this year. Thank you. I appreciate it. And your talk was very, very informative.
Good. Thank you.
Mm-hmm.
I have a question. Indeed, doctor, thank you very much for a fantastic talk. And my question is, what is in the horizon for IPF as far as new treatment, new hope? And is any the research being done for COVID? Could that be reflected also on hope for IPF patients?
So I'm going to go the last part of your question first because it's easier. So the COVID research is pretty much all focused on treatments. And what I'm very interested in now is thinking about what's happening to the people who are post-COVID and have now lung disease and long-term problems. I think that's a whole new area that we're going to be researching. In terms of what's on the horizon, now there are 3 or 4 clinical trials currently underway or beginning. I will say, when COVID started, every clinical trial in the country and probably the world shut down temporarily. Everybody is starting back again with the research and starting back in. So there are 3 or 4 new trials and new drugs. Unfortunately, I wish there was one out there that I could say looks promising for reversal. We're still looking at maintenance, and I'm hoping that the idea of precision medicine and genetics, that we get better at this and we're able to reverse it. I know there are people looking, but it's nothing ready for prime time at this moment. Stem cell research is still very much so in its infancy right now. We wish it was further along, but it's just in its infancy. There are some promising things going in other parts of the world, but not in the United States at this point in terms of stem cell research. That's, hope-wise, we're still in maintenance, but there are a couple of drugs I am hopeful for in terms of minimal side effect and slowing rate of progression. We'll see what happens. starting their trial, so I don't know what'll happen. Maybe 2 or 3 years from now, I'll have an answer for you.
Thank you, Dr. Mageto. I have a question. Are there any specific biomarkers to help determine if there's an environmental cause for UIP? I just recently had a biopsy that confirmed the radiology impression, and all the autoimmune tests that I took were negative, although I did have a low ANA 160. So I don't know where we're going to go from here.
So this is where it gets complicated, and this is where the nuance come in. So let me sort of just give you a story of a patient who was followed by Dr. Ragu, one of my mentors. And Bill, you may remember the story, but she was in her 20s. I remember when he diagnosed this young lady with IPF, but we don't see IPF in 20-year-olds. But nevertheless, like you, no other findings. And it wasn't until almost 20 years later that she developed all the autoimmune signs. So here's one of the problems with this, even with IPF. You may have what looks like IPF, and 2 years from now have every indication that you have an autoimmune disease. I don't know what your doctors will do next step, without knowing everything involved. But it's a difficult. You're getting to where appreciating that there's difficulty in managing, and this is, in my opinion, this is a one-on-one, and that's why we do these things at the ILD centers.
Yeah, I'm waiting for the multidisciplinary team to meet together and go over everything that they have to work with. I'm 60 years old. It seems like I would have had some indication of an autoimmune disease before now.
Oh, fabulous.
Thank you.
Dr. Mageto, I'm asking for I guess feedback, and it's not fair to ask for the feedback, but I haven't seen any published numbers or stats or information. I've heard from people that know that the incidence of fibrosis and fibrotic disease in COVID patients that are being discharged on a long-term basis is very high. Is that going to bring perhaps a focus of the medical community more so on ILD because of that great broad and depth of awareness that's taking place?
It's going to be dependent on how politically you get to play this game. I'm just going to be honest with you. Everybody's so COVID related. It's a magic time to get somebody to put some money on it. And people are throwing money at COVID right now. So if you want to throw money at a grant that's going to look at this, I bet you money this would be one way to start getting that look. I mean, the question is this pulmonary fibrosis the same as the IPF? Is it different? Does it behave? So I think there's room here to get attention, to make that a segue to getting attention to PF and ILD across the board. There's a lot of room.
Dr. Mageto, I have a question. I have a systemic scleroderma, and I was diagnosed about 12 years ago. I'm on OFEV now, and autoimmune suppressants and Plaquenil. And recently, in the last few months, instead of just one Mucinex a day, I need it both morning and night. And also I've been taking the NAC now in the morning and at night. What is your take on Mucinex and NAC?
So let me just clarify, are you noticing you're making more, you're having more mucus? Is that what you're telling me?
Yes, at times. And then other times it's just the dry cough, but I can feel the mucus at the back of my neck, in my throat.
So the reason I ask that is because one of the things NAC can do, it can increase your mucus production. So you can actually bring up a lot. When we used to use it a lot for pulmonary fibrosis before it went out of vogue, I had a number of people who, and actually if you look it up, you can actually have a lot more secretions with NAC. In terms of whether it will hurt you or harm you, it's one of those things right now. If it's not hurting you right now, people probably would say just stay on it. nobody knows that it actually does anything either direction.
Okay, thank you very much. And then what about the Mucinex?
If
I
it's,
take 600, the non-drowsy 600 in the morning and the evening.
so in my practice, I usually say if it's helping you and it's not hurting you, go with it. But if it's not doing anything for you, then you probably want to talk to your doctor about just stopping it.
Okay, thank you very much. And thank you for your time and all your information today.
Getting off when I see helps you.
You're unmuted, Shelley, but go ahead.
I was going to make a comment.
Well, I was going to comment about something that I forgot what it was, but I will say that the last speaker in her situation with mucus production, I had the same complaint. Now I have RA-ILD, and I also have a lot of seasonal allergy issues. So my cough comes from, I think, from the mucus touching my vocal cords and triggering a cough. So I'd like to control my cough, but I came to Dr. Mageto, who is my doctor and a very good one. And I brought the problem that you have just stated to her, and I was taking a lot of NAC, and I was taking Mucinex as well. And she gave me the same comments, that she just made, and I discontinued taking the NAC, and I almost noticed an almost immediate improvement within just the next few days, that I was actually producing less mucus and I was having less trouble. So that's just a testimonial from me. But yeah, I'm perpetually having problems with that, and I do take other supplements, to try to help that. But drinking lots of water too helps mobilize mucus. So I try to drink as much water, and that helps as well.
Dr. Mageto, also, talking about a road trip, somebody mentioned that earlier. We actually could drive to southern Colorado to a little town that has good air, not too much elevation. And, when you drive through Northwest Texas, you really don't come into contact with many humans at all. And we've thought about doing that just because Dallas is such a hot spot, and with the kids going back to school and bringing probably COVID home, that, we have wondered about doing that, and just wonder if you have any suggestions about road trips.
That is a loaded question, Shelley. Okay, so I like road trips personally. In fact, I'm going to be taking my daughter to college on a road trip or two. Not that I think the thing with road trips and COVID, you are going to have to be careful where you stop and how long you stop for. I know a lot of people are doing RVs. Possible, minimizing your stops, know where you're going to stay. I mean, I don't think it's impossible. I just think it needs to be very carefully planned.
Dr. Mageto, I'd like to, if I can, may I comment on the whole thing about NAC, which it's an ongoing puzzle. I think that I've been living with it now for 9 years since I first started taking it 9 years ago. I don't take NAC for PF. I take NAC because it's mucolytic. It thins out the mucus. It doesn't really produce mucus. It thins it out. It might give you the sensation of having more, but thinner mucus means you can cough it out easier. That I take it for that reason. And then secondly, it's also the nature's #1 best supplement for glutathione, which is an anti-inflammatory. So for those two reasons, and there was a test done by Cleveland Clinic about 6 years ago, small test that had 30 people in the test. What they found was, based on your genome, some people respond positively to taking NAC, and some it actually exacerbates PF. And so who knows? I've been taking it for 9 years. I'm still walking, talking, and chewing gum, so to speak, so it hasn't hurt me. And I think it's one of the key supplements in my regimen of what I do to help myself, but not because it's going to help PF to me. It helps me deal with PF better.
Well, it's also a really good antioxidant. And I think about it, I remember the studies. One of the things, though, that are a little bit different, and one of the problems with NAC and any of the others is that it's hard to know with the over-the-counter stuff how much is in it or how pure it is. Now, if you can get straight glutathione, you might not have as much of a mucolytic effect, but still get that antioxidant effect of the NAC. And that's been the biggest problem with all the over-the-counter stuff, is that as much as we love it, the question is, are you getting the right brand that's delivering the right stuff? And since it's not regulated, some of it's by reputation. I think there's consumer labs, there's several sites that sort of test this stuff for you and will give you information as to whether it has what it says it has.
Dr. Mageto, on familial IPF, is there any kind of progress being made on understanding that and trying to figure out what's happening? That seems to be a very aggressive form of IPF.
So there's probably Chad, who's going to be, I think, speaking in 2 weeks or so, will probably know more than I do. I do know that there's still ongoing research. I think, and I know we have actually sent a good number of referrals to Denver, who's doing research on this, and Christine Garcia, who moved to Columbia in New York, is still also doing a lot of research on this. But the answers are still not there. I think everybody's still in the lab, and I think COVID upended the world, so we're probably now where we were before this started. So nothing new yet out of the genetic side. Nothing that I'm aware of.
Dr. Mageto, this is Russell Amling from Tucson, Arizona calling, and I am a pulmonary fibrosis and bronchiectasis or bronchiectasis patient. And has post-polio syndrome ever had any significance to pulmonary fibrosis? I had polio when I was 11 years old, totally paralyzed, and I still have polio problems at 87 years of age.
So the question is whether the polio has anything to do with the pulmonary fibrosis?
Yeah.
As far as I know, no. I've got 1 or 2 post-polio syndrome patients. There is no known association between the two. At least that we are aware of. And I have to admit, we don't see a lot of post-polio syndrome patients anymore either.
Well, we're getting old, and that's 90% of it. And as I said, at 87, I belong to a polio epic group, and I'm learning more as well medically from that viewpoint. And I received invitation from Mr. Vic here to join this group today. And it's been a intelligent information for me. It's also been a blast, but because of my polio, I've had other problems health-wise, and I still have swallowing problems. I have weakness of all my muscles. I know that we started a program of exercise, and I cannot do that because of the weak muscles in cardiac rehab and pulmonary rehab. And I haven't been able to do it. I love getting out in the area. I like to walk, but again, because of my pulmonary fibrosis, the breathing is getting tougher and tougher. Sorry, I'm taking so much time. Apologize.
Russell, not taking time at all, and it's really valid information. But Dr. Mageto has a secret she hasn't shared with us. I have to share, because it's her daughter's birthday, and she's taking time from her day and her daughter's birthday to speak to us. And I'm not sure we can do a round of applause and a stand up and an attaboy, but you got them in droves here, Dr. Mageto. It's been a wonderful presentation. Thank you. Thank you. And we're going to close down. We've been here for 90 minutes. I appreciate your time so
Tell your
much.
daughter happy birthday from the Warriors.
That's right. All the Warriors said happy birthday for sure. And thank you so much for being here. And watch for our next meeting coming up, and watch for some news that we're going to share in about 2 weeks that I think is surprising and really exciting news that I'm excited to share with you. So thank you for all for being here for Saturdays and being here. It's been a great meeting. Dr. Mageto, I'll say it again, best meeting that I've ever been to. Thank you so much.